안녕하십니까. 온라인
Greetings, I'm Dr. Kim Kyung-won of Online Surgery. I'm honored to be with you today. This is patient x-ray at initial visit. This is 76-year-old male patient, and you can see that on the upper right posterior area, the teeth are missing. If you look at number 16 and 17 and 47 in the lower, they are missing. In number 16, extraction was performed in a private clinic 3 months ago. Sinus graft was necessary in number 16 and 17. If you look at patient's past medical history, the patient has been diagnosed with gastric cancer, and currently he is proclaimed to be fully cured. If you look at the patient history, he did not go through laparotomy. He had endoscopic surgery. Despite having gone through cancer therapy, the patient continues to smoke 1 pack of cigarettes per day. Because sinus graft was necessary, recommendation was made to quit smoke. However, despite having had gastric cancer, the patient continued to smoke, so this was deemed impossible. Surgery was planned as is, and the sinus graft was to be performed in the upper right side. Sure-os and AOS layered graft was planned, the lateral approach was planned, and round burr is going to be used, and conventional procedure is going to be proceeded. 2 implants will be placed in number 16 and 17, and GBR was anticipated to be necessary, and the implant was planned in number 47. This is CT in number 16. Extraction was done about 3 months ago, and you can see that there's a bit of palatal and buccal alveolar bone, but the extraction socket is not fully healed and bone graft may be necessary, so GBR was planned at the same time. This is image taken upon surgery, and you can see that burr was used in a conventional way to form lateral window. I'm sure you're going to see it in the video later, but the patient has been smoking for quite a long time, and the sinus membrane was very thin. Perforation occurred. I used the Fibrin glue, which I love, to repair it. Bone graft was done, and in the extraction socket, AOS bovine bone was used for bone graft, and GBR was performed. This is immediate post-op, and you can see that in number 16 and 17, 2 implants have been placed, and within the sinus, bone graft has been performed. As mentioned earlier, in the extraction socket area, bone graft was done and GBR was done, and in number 47, implant was placed. This is immediate post-op image, and in number 16, you can see that implant was placed at the same time, and graft has been performed in the sinus. In the extraction socket, bone graft has been performed, and in number 17, as you can see, sinus graft along with implant placement was done simultaneously, and in number 47, freehand implant was placed. This is at initial visit, and this is immediate post-op, and about 6 months later, second surgery was performed. Significant bone grafting was performed, but after 6 months upon second surgery, you can see that a lot of bone graft materials have been resorbed, and although we have repaired the perforation on the sinus membrane because the patient continued to smoke, I believe bone formation occurred less. Upon second surgery, if you look at CT, up to implant apex, bone formation is nicely done. In the area where GBR was done in the extraction socket, healing is nicely occurring. In number 17, bone formation is nicely done. However, ISQ value is slightly lower. ER-type prostheses have been delivered. And if you look at the initial visit situation, sinus bone graft was performed, and in the extraction socket, bone graft was performed, and it is maintained relatively stably. An implant has been placed in the lower, and prostheses have been delivered. Let's look at the surgical clip. Incision has been made from the distal side towards the mesial side. It is a distal free end case, and the vertical releasing incision has been made, and you can see that ablation is being performed on the lateral wall side. You can see defect in the extraction socket. The round burr is used to form lateral window. It hasn't been that long since extraction has been performed, and the bone thickness on the lateral side is thicker than anticipated. It is over 1 millimeter, and lateral window was formed. Sinus, it looks okay, but the patient is a frequent smoker, and in the extraction socket area, you can see tearing. In the case of sinus membrane tearing, even if perforation has occurred, you need to lift the sinus membrane fully, and now preparation is being done in the area where implant is going to be placed. You can see that on the lateral side, there is less bone. Twist drill is used. Position is confirmed. Preparation is being done. Parallel guide pin is used to check implant position, and antagonist relation is being checked. In the distal area, in number 17, lance drill is used to mark. In the case of number 17, it's been quite a while since extraction has been performed, so there's no longer extraction socket. The parallel pin is used to check the relation with the antagonist. Occlusion is checked. 3.5 by 8.5 1-2 taper drill is used to prep the implant site. I'm not doing it full length. In number 17, preparation is done, and 4.0 by 8.5 1-2 taper drill is used to expand the site. 5.0 diameter implant is going to be placed, but I'm going to prep up to 4.0 diameter graft material. I'm going to use a SureOs and AOS, so allograft and xenograft. This is pen type, but my recommendation is to do sinus graft separately. SureOs is used in the area where implant is in direct contact with the inferior margin. Allograft is used, and on top of it, the xenograft is used. The layered graft method is used so that we can take advantage of the two graft materials. KS3BA 5.0 by 10 millimeter implant is placed in number 16 first. As shown, KS3BA 5.0 by 10 mm implant is placed after irrigation, and in number 17, KS3BA 5.0 by 8.5 implant is placed. Implant placement is done, and primary stability is about over 15 Newton centimeters. Position is checked. In the extraction socket area, there is a very little buccal bone plate. Mount is used. It is placed simultaneously with the sinus surgery, so you need to be careful. Cover screw is connected. Within the sinus, bone graft materials are being augmented, and bovine bone is used. In the area where sinus membrane is perforated, fibrin glue is used for repair. In order to make sure the graft material does not disperse within sinus, tissue adhesive is used. On the buccal side, as shown, there is defect. In this area, the bone lid, which has been taken from the lateral window. The cortical bone was quite thick, so graft has been performed on this side. This is a type of autogenous bone graft, and we want to augment the buccal wall. On top of it, AOS bone, xenograft material is used to add bone graft on the extraction area and the defect area. Bone graft is done in number 16 primarily, and the same for number 17. Fibrin glue is used to fixate the graft material. Fibrin glue cannot serve the role of membrane, therefore OSSTEM is used. Membrane is applied here so that the bone formation can be done nicely in number 16. GBR has been performed as shown. Suture is now going to be done. Suture is done. I believe the time where it is exposed to oxygen needs to be minimized, so full suture is going to be done, and then surgery for the lower is going to be performed. The mesial tooth is going to be used as an anchor, and the suture is done. GBR has been performed in the extraction socket, but there's no significant strain on the flap itself, so no releasing is performed. In the area where vertical incision is made, interrupted suture is done, and in the back, figure of 8 suture and interrupted suture was done. In the lower, incision is made from the distal to the mesial side. In number 6, incision is made from the distal side and flap is reflected, and then implant placement is going to be done. Lance drill is used to check the position. Cortical bone is penetrated to check the position. As for the lower, it's been quite a while since the tooth was missing, so bone was not very good in terms of quality. 2.2 twisted drill is used, and up to 8.5 millimeter drilling has been done. Parallel pin is used to check a relation with the antagonist. The position looks to be favorable. 3.5 by 8.5 millimeter 1-2 taper drill is used. This is followed by 5.0 by 8.5 millimeter 1-2 taper drill. In the lower posterior, the bone quality is not excellent, but up to 5.0 drilling has been done, and BA surface 5.0 by 8.5 millimeter KS3 implant is being placed. Initial torque does not look to be excellent considering that it's lower posterior. You can see that depth adjustment is being done. The mount removal is done. And cover screw is connected. In the upper, second surgery is necessary. Cover screw was used and suture was done. In today's surgical clip, because the patient was a frequent smoker, the sinus membrane was very thin, and during surgery it was perforated, and in that area fibrin glue was used for repair, but in terms of implant survival itself, it's not going to be an issue, but in terms of wound formation, it may not be as favorable. In the case of lower, implant has been placed in a conventional way. Thank you for watching.